invite Dr. Duru Shah, who's the director of the Gynec World, the Center for Women's Health and Fertility, founder, president of the PCOS Society India, founder, trustee of Women's Empowerment Foundation, and the trustee and past president of the Mumbai OBGYN Society. She is also the chair of the Special Interest Group on Reproductive Endocrinology at Aspire and an international advisor at the Special Interest Group of ESHRE. She is also chair of the Indian Special Interest Group ASRM and past president of ISAR, FOXY, and Indian Menopause Society. She's also been the past director of the digital education for the International Menopause Society and the past chair of Indian College of Obstetrics and Gynecology. She was the first and the only one to receive the FIGO Distinguished Merit Award for her work towards women's health. She would be talking to us today on PCOS and ART, preventing complications. Over to you, Duru.
Thank you so much, Madhuri. I'll just share my screen. Great. Okay. So I'm going to talk. I need to open this up and your top screen.
Just on the show, just make it as show.
No, but I'm not able to see it because of the screen on the top. That's the problem.
Down, you just go down and.
I'm trying to do that. I think I'll continue this way.
No, I think you press on the show. You can go at the top and then you go to the
slideshow. I'm not seeing the slideshow. That's the problem. New share is showing up.
No, go down right at the below.
Yeah, below it's. Just give me a minute. You're seeing my screen, right?
Yeah, we're seeing your screen, but it's.
I know I'm not able to open it for some reason.
Yeah, okay, you can go like that then. That's fine.
Okay. Okay, my talk today is on increasing, actually I'm not able to see my own slides, I'm so sorry. Can you give me a minute? I'll just try and...
Yeah.
You can take some questions in the meantime.
Yeah, so I'll go to the questions. So there are two questions for Louis. One is instead of FSH plus HCG, can we not use HMG directly in hypo with PCOS?
Absolutely, and many people would use that as the first option. It just depends a little bit on the availability and cost, but HMG is a very good option, and often people would use that first. There's also now Pergoveris, which you can use, which is a recombinant as well. So any of those three, traditionally we've used FSH with LH as in combination, but I think increasingly now most people would start with HMG.
The second question is in hypo, wherein you're using FSH and HCG. What is the dose of HCG given for trigger?
We would still use 5,000 for a trigger. And then if we need any luteal support, we use 15,000, usually on about day 3 or 4 and day 6 or 7.
There's another question. What's your experience or have you noted a difference in response between HMG and REC-FSH plus REC-LH in the hypo-hypo group? And she's also asking, I recently had a hypo-hypo patient who ovulated pre-OPU despite giving antagonist for the last 3 days of stimulation.
Okay, sorry. Can what was the first question? Was the difference between Recaval and HMG?
No, it's between HMG versus REC-FSH plus REC-LH.
Okay, so there are some combinations. There is a medication that has REC-FSH and REC-LH, but it's in a 2-to-1 ratio with more FSH than LH. So you end up having not quite as much LH. The HMG is in a 1-to-1 ratio, so you'll get a little bit more. It'll take a little bit. You'll get a little bit more FSH stimulation before you get the androgen production with the REC combination drug compared to the HMG. If you want to use them independently, you could bring them back to a 1-to-1 ratio. I think they all work pretty well. I don't think there's been any big studies that have shown a difference between those drugs because it's such a small group of people, and our experience is that they all work reasonably well, but sometimes you have to wait a wee while to get the androgen production in place for the FSH to work.
Sujata, there's a question for you. Is there any minimum or maximum punctures you do in LOD? And what is the minimal distance between the 2 puncture sites, minimum and maximum number of punctures?
I think currently they are recommending 4 to 12. But as I said, there is no proper evidence. I don't know distance between, there's nothing like that. But then you have to take randomly about 4 to 12 holes in the ovary.
Yeah, I think Dr. Duru has got with her slides. So
yeah, can I go ahead?
Yeah.
Okay, sorry for that little bit of disturbance. I just couldn't see the play button, so I couldn't get it shared completely. Anyways, my talk today is on improving pregnancy success in ART, and we know that in modern times there is an increasing efficiency of ART today because of better understanding and techniques of science. There are, of course, because of that, there is increasing complications, especially in PCOS women, where we do have the 2 major complications of ovarian hyperstimulation and multiple pregnancies. We have increasing awareness on this subject of OHSS, and hence there have been strategies which have been devised to reduce these complications. And these increasing strategies have been developed so that whilst we are reducing the complications, we are also making sure that they are not affecting the pregnancy rates. I think keeping that in mind is very important because there could be strategies which you could use and then there would be no pregnancy otherwise. So let's go ahead with what really are the complications during ART treatment. They may be either associated with treatment, such as the side effects of the drugs. Hyperstimulation, of course, is high on the list. It could be associated with either the sedation or the anesthetic used during the surgical procedure of ovum pickup. It could be a risk associated with hemorrhage or infection during oocyte retrieval, or in the male partner, it may be the surgical sperm recovery risk, like infection, bleeding, or testicular atrophy. If it is associated with outcome, the commonest one is multiple pregnancy, and we do have a higher chance of having ectopic pregnancy and heterotropic pregnancies, and of course, congenital anomalies in children. There is further evidence required for these suggestions of complications which have been suggested in the past, which are borderline ovarian tumors, childhood cancer risk, and imprinting disorders in the children born to mothers who have been, with multiple pregnancies. So we know that OHSS is an iatrogenic condition and it can be prevented and it can be diminished in its severity. Its estimated prevalence in its mild form is about 20 to 33%, whilst the moderate to severe form may vary anywhere between even 0.5% to some states as 88% in some areas where these treatments are not carried out very carefully. The number is higher for the high-risk women who are PCOS, who are known to have multiple follicles. And whenever there is a patient, even if she doesn't have PCOS, but she has a large oocyte yield during the ovum pickup, she also is at a high risk of ovarian hyperstimulation syndrome. So let's see what really is the pathogenesis of this disorder. And let's start with, when we give hormones to our patients like gonadotropins, the intention is that we want to produce more number of follicles, which we can aspirate and create embryos. It does not make sense for us to aspirate one follicle, and therefore multiple follicles are developed. And these large number of growing follicles release a large amount of estrogen. And along with it, there is an extra release of VEGF, that is vasoendothelial growth factor, and the receptors attached with it. Now, these receptors peak after 48 hours after giving the trigger or after giving the HCG injection as a trigger for releasing the egg. When you deliver the HCG, it combines with the VEGF receptors. And this then finally leads to increased vascular permeability and increased angiogenesis, which makes the fluid from the intravascular space to go into the extravascular space, leading to abdominal distension and increased intra-abdominal pressure. The loss of fluid from the intravascular space going into the extravascular space causes hemoconcentration, which then causes thromboembolism and in various organs, and it can give rise to multiple organ failure. This ovarian stimulation, when it occurs, it also causes a lot of ovarian enlargement because of multiple follicles getting stimulated. The capillary permeability makes protein-rich fluid go out into the third space, and this also causes a lot of ascites in the abdominal cavity. It can cause pneumothorax in the pleural cavity, and it can also cause fluid in the pericardial cavity. So with all this pathology going on within the abdomen, and of course to the other parts of the body, it could cause serious disorders to the woman and sometimes can lead to a mortality. So in short, we need to make sure that when we are treating our patients with for IVF, or when we are doing ovulation induction stimulation for IVF, we should try and avoid complications which can cause serious harm to these women. Now, the clinical classification of OHSS has been mentioned long back, right since 1967, and it has gone through various modifications as science has grown, as information has increased on a subject. We have now come to the last classification which has been reported, and after which there's, I don't think, anything more. This was by Abulgar in 1999, and he graded it as grade A, B, and C. And in grade A, the symptoms were mainly dyspnea, oliguria, nausea, vomiting, diarrhea, abdominal pain, clinical, and then on examination, there was clinical evidence of ascites, marked distension of abdomen or hydrothorax, and ultrasound showing large ovaries with marked ascites, but the biochemical profile is still normal. So that's grade A. When it's grade B, there is over and above the grade A, you will have a lot of more ascites with massive tension in the abdomen, markedly enlarged ovaries, dyspnea, oliguria, increased hematocrit, elevated serum creatinine, and liver enzymes being also increased. And then you go to grade C, where there's respiratory distress syndrome, renal shutdown, or venous thrombosis. So when you look at OHSS, we know it occurs mainly because of ovarian stimulation, but sometimes there have been case reports reported of spontaneous OHSS, which are very, very few in number and probably could be due to the FSH receptor gene mutation. And it is usually iatrogenic, as I mentioned earlier, because of high doses of gonadotropin, which we use. And the reason why initially, when initially IVF was started, a large amounts of gonadotrophins were given, and at that point in time, the concept was that more the number of eggs, better are your chances of getting results. And hence, a lot of stimulation was done in those days. There is the early OHSS, which happens usually very soon, within a week of using HCG as a trigger, and it is based on high estrogen levels. And then you have the secondary or the late OHSS, which occurs later, about almost a week or 10 days after the trigger. And that is because there are too many corpora lutea, there are too many follicles which have ruptured, and all this together will cause a rise of HCG, especially if the woman has become pregnant at the same time. And if she's got multiple pregnancy, the pregnancy itself is releasing more HCG. And that HCG, when it is released, is causing further and further stimulation and increase in the size of follicles and corpora lutea. So this is where the early and the late type of OHSS is concerned. And this is something we need to understand, that just because she had it earlier, she won't get it later in the cycle, but she would get it later in the cycle if she becomes pregnant in the same cycle. Now, why does this OHS occur in only some selective women? It doesn't occur in all. But what it has been shown that there could be some heterogeneity in the production of soluble proteins that bind to the VEGF and regulate its activity. With women with OHSS have known to produce less soluble VEGF receptor versus women who do not develop OHSS. So the less soluble the VEGF receptor is, higher is the amount of OHSS. It could be due to difference in sensitivity to the gonadotrophins, like some women may be more sensitive. It could be mutations in the FSH receptor that allows HCG to bind very avidly to it. So there are various reasons why it occurs in selective women, but we must remember that a woman's individual risk of OHSS may be determined by factors other than her vigorous response to ovarian stimulation. So whenever we are inducing ovulation, even if the dose of gonadotrophin is not very high, you may still get a sort of a hyperstimulation, especially keeping in mind PCOS women who are more sensitive to it. The risk factors for OHSS, of course, first on the top on the list is PCOS, increased AMH, young and lean women who are less than 30 years versus more than 40 years, high serum estrogen prior to the trigger, retrieval of more than 30 oocytes at a time, pregnancy following fresh embryo transfer. As I mentioned earlier, as a woman becomes pregnant, she's releasing, there's more and more in release of HCG, which can cause late OHSS, and the large number of follicles in the ovaries. Then after hyperstimulation and after assisted reproduction leading to hyperstimulation, there was a very nice data which was available, has been available very recently in September 2020. This is data from NAS, which is between 2000 to 2015, which is maintained by CDC from approximately 97% of IVF cycles in the US. The total cycles listed here are 1833430, and it includes both autologous and donor embryo transfers, and fresh and banking cycles have been included, all of them, and the rates are calculated for moderate or severe OHSS, or there are some cycles where they don't mention what kind of OHSS it is, and then they would put it as just presence of OHSS. So that is included in any OHSS. And then they looked at various factors. And one of the factors they looked at was the GnRH antagonist use per 1,000 IVF cycles. And this results, what they got was that from 2000 to 2006, the OHSS increased from 9.96 cases to 14.34 cases per 1,000 cycles. But from 2006 to 2015, the OHSS significantly decreased to 5.27 cases per 1,000 cycles. And it was found that when they correlated to the various parameters which were there, now this is a data study. This is a study from the data which has been, sort of collected by the agency whose collecting all the data for 15 years from 2000 to 2015 of IVF cycles in the US. So there was a significant increase in the use of antagonist from 279 cycles, 279 cycles antagonist was used per 1,000 cycles of IVF. And over this period from 4 to 15, the numbers increased 3 times with the use of antagonist. And probably that is why, if you see in this chart, what is going up is the rate of severe the use of antagonist. That's the only graph which is going up. That is the use of antagonist, whilst all the other hyperstimulation rates, moderate, severe, all or any type of OHSs, all of them are going downwards, commencing from 2006 onwards. So they have correlated it and said that it is probably the use of of antagonists which has helped it. Now, the pregnancy outcomes in women who develop OHSS, if you look at this, there's a very limited and conflicting information on this. There are some studies which talk of higher rates of early pregnancy loss. There are some studies who talk about preterm delivery, low birth weight babies, pregnancy-induced hypertension, gestational diabetes mellitus, biochemical pregnancies and embryonic pregnancies, missed abortions. All this in women with early OHSS compared to late onset OHSS. So in short, there have been outcomes in women who have actually developed OHSS, and this is what happens to them once they get pregnant, and it gives rise to problems, but they have not mentioned any adverse obstetric outcome in either of these two groups when they have compared early OHSS versus late onset OHSS. Even if you look at the outcome of those pregnancies which have occurred after fresh autologous cycles and the pregnancies which have occurred with multiple gestation, in all of them it has been shown that the cycles with OHSS will have a higher risk of second trimester loss, stillbirth, and the birth weight will be less than 2,500 grams and increased risk of preterm delivery. So the observations made by the study were that OHSS is a serious complication which affects women undergoing ART and their pregnancies resulting from it, and the effective means available to reduce the risk of this hyperstimulation are various. So what has been suggested is that there should be a careful controlled ovarian hyperstimulation so that you should not try and achieve more than 15 mature oocytes at a time. Use GnRH antagonist as a trigger, as a ovulation induction protocol, and use GnRH agonist trigger in high-risk patients, especially PCO patients. Use of metformin and low-dose aspirin in patients at high risk of OHSS. Use of cabergoline at the time of trigger, and maybe you can freeze the embryos and transfer them as frozen thaw cycles. Means we call it as segmented IVF, where the first segment is where you stimulate, you retrieve the oocytes, create the embryos, freeze them, and then in the next cycle, when all the hormones have settled down and the ovaries have come back to normal, in that thaw cycle you would transfer. So these are the suggestions or the observations given after this large study. There are a whole lot of variables studied, but I mean, I cannot go into all details, but basically these observations have been made based on the data which was collected. Now, the strategies, of course, have been many, and I mentioned these earlier, but there's enough evidence today on use of GnRH antagonist protocol for COS in PCO patients, use of GnRH agonist as trigger instead of HCG, use of vitrification for freezing embryos and then transferring in the next cycle, and use of cabergoline at the end of stimulation. So when we talk about all these parameters, or we talk about these strategies, as we mentioned, when we are using the antagonist protocol, we are actually suppressing the LH. The idea of using it is to suppress the LH and to prevent it from causing premature luteinization because of the high estrogens. And we must make sure that instead of using agonist, we would use antagonist, which would be very useful. The use of GnRH agonist as a trigger can be used when we use an antagonist cycle, and the agonist has got a short half-life, and therefore it would definitely help to reduce the amount of HCG sort of in circulation. And the use of vitrification for freezing embryos, because by then when you put the embryos into the next cycle, there is a, sort of, there's no endometrial and embryo asynchrony which is occurring. They will be in synchrony when you put them into the cycle, in the next cycle when the hormones have not been high. And by giving cabergoline at the end of stimulation, you're basically attacking at the level of the VEGF. So by doing all this, you'll be able to make sure that the patient does not develop hyperstimulation. Now, this is another study, which is the Cochrane database of systemic reviews in 2017, where they talked about reducing complications and optimizing the pregnancy outcome in assisted reproduction, so that whatever you use to reduce the complications, but at the same time, how you can optimize the pregnancy outcome. So we had, this study was identifying regimens for COH and ART, which not only reduce the chance of developing OHSS, but does not compromise other outcomes such as pregnancy or live birth. So in this, 27 reviews have been included. And this database was initially last done in 2015. And over and above, that was done by Farquhar et al. And this data has been added on to that, those reviews which were taken in at that time. And they use the AMSA ratings to assess the quality of included reviews and the GRADE method to assess the quality of evidence for each outcome. The results were, they looked at the evidence of moderate and high quality evidence considered as interventions in reducing OHSS. So they said these were the high quality evidence which we have, where you give metformin treatment during and after an ART cycle in PCOS. But there have been studies which have been shown that if you give metformin only during the ART cycle, they may not be as effective as starting metformin a little earlier. So in short, looking at giving metformin only to reduce hyperstimulation, maybe you may be able to help, but if you're going to look at increasing the pregnancy rates, you may have to start metformin earlier, especially in PCO patients who may have insulin resistance. The GnRH antagonist protocol in the ART cycle, of course, has been mentioned, and GnRH agonist trigger. So there is enough high quality evidence to say that these three interventions are definitely going to reduce OHSS. Whilst there is evidence of low or very low quality evidence for the use of clomiphene citrate, there are some who recommend that you use clomiphene citrate along with a smaller dose of gonadotrophins to reduce the problem. Then the next is giving cabergoline at the time of trigger or ovum pickup. Again, there is not enough high quality evidence on that. Giving IV fluids or plasma expanders at the time of trigger. Again, there is low quality evidence. Then giving progesterone for luteal support. They say there's low quality evidence, but I have to defer on that personally. And coasting, which is withholding gonadotrophins. Now, all these are, interventions which have been tried, and probably there have not been enough studies done to confirm whether really there is better quality evidence available for the same. Now, there are effective interventions on reduction of hypertension with a positive impact on live birth rate. So this is a chart created wherein the clear triangles are suggestive of hyperstimulation and the dark triangles are suggestive of live birth or clinical pregnancy. And the odds ratio is on the vertical bar, and the various products, interventions used are below. So if you see with metformin, that's the first one, you'll find that the live birth or the clinical pregnancy definitely is increasing above the odds ratio of 1. It's almost touching 1.5. There is also at the same time reduction in the ovarian hyperstimulation. So if you see all these products or interventions which have been used, all of them are definitely reducing the OHSS. But what is really helping also with improving pregnancy rates is the metformin, and then also the one of the volume expanders which is being used. So here you have all these parameters which have been put up, like the GnRH trigger. When we use a GnRH agonist trigger, there is some amount of a luteal insufficiency which develops, and therefore we need to give progesterone in those patients in order to get better pregnancy rates. If we just use an agonist and we are not going to transfer the embryos, then it's fine because we are not going to transfer the embryos. But if we are going to transfer the embryos in the same cycle, then we need to add progesterone to improve the endometrial receptivity. So in short, this is talking about the different interventions. So interventions that aim to reduce this incidence of hyperstimulation can be targeted at different portions of the ART cycle. So first of all is in identifying the high-risk populations so that we can decide what kind of a protocol of ovulation induction we should use. So the high-risk population is what we have to look for. And of course, we all know that PCOS becomes the high-risk, one of the major high-risk population. Patients with a high AMH also are known to have this problem. Prevention of recurrent hyperstimulation is another thing we have to see, that if in the previous cycle the patient has had hyperstimulation, probably she may respond the same way. So we need to adjust the dose of the gonadotrophins in the next cycle. Just like Louis had talked to us about a patient where they used a small dose, but still there was hyper, and therefore in the next cycle they gave a smaller dose. So you have to adjust the dose according to what happened in the previous cycle. Then you have to prevent large number of follicles by tailoring the ovarian stimulation, so that you use different treatment regimens. You use use of adjuvants like cabergoline, which will prevent a rise of VEGF levels. And at the same time, you must use interventions like metformin. You have to reduce the dose if you find that the follicles are growing too fast, or if the estrogen levels or estradiol levels are going too high. We need to withhold the gonadotrophins, and this is called coasting, where we continue the antagonist and we don't do the stimulation with the gonadotrophins. But it has been found that if the estrogen levels don't decrease within 3 days of coasting, then we have to cancel that cycle, because further coasting is not going to get you good pregnancy rates. So in short, we have to make sure that we avoid the estrogen levels to go too high, the follicles to increase too much in number, and therefore a lot of experience is required in adjusting the dose which we are giving for the stimulation. Then when we do the trigger, it's important that we use the agonist trigger rather than using HCG, as mentioned before. And if we find that still this patient is likely to develop a lot of hyperstimulation, then it's best to prevent a pregnancy by freezing all the embryos and transfer them back into a subsequent cycle. Now, when we are doing assisted reproduction, we know that we all wish as doctors that we must help our patients and get them good pregnancy rates. But at the same time, we want to make sure that we don't create complications for them. So as I mentioned earlier, that OHSS can be a very serious complication. At the same time, in the past, I remember there were a number of embryos transferred at the same time. We didn't have a good vitrification. There was no vitrification at that time when IVF started. And I'm sure people remember that in the front headlines, when they used to have 6 babies and 7 babies and 4 babies, they used to make headline news that so many babies born of IVF. But today that is being considered as a complication of IVF. And therefore, we must know that the number of embryos which we transfer should be such that we should get a good pregnancy rate, and at the same time, we should not be harming the patient. And hence, this is one of the factors which affects treatment outcomes of ART. It has been shown that more the number of embryos you put in, higher is the pregnancy rate. But it has also been shown that even if you put more than 2 embryos, you're not going to get a higher pregnancy rate. You're just going to get a higher complication rate. So this is what we have to keep in mind, that this multiple pregnancy is today considered as a complication, and we need to avoid it. And it is multiple pregnancy is the single most adverse event of ART, which is 20 times higher than spontaneous pregnancy. It's a high risk to the mother because it increases the miscarriage rate, pregnancy-induced hypertension, GDM, increased hemorrhage, increased instrumental delivery, and preterm labor. While the risk to the babies is increased prematurity, small for gestational age, low birth weight, then hospitalization is required or in the NICU. There's increased perinatal mortality, and more than that is the long-term health and cognitive risk which are these babies are subjected to. So here you will see that as the years have gone by, we have actually made an attempt to reduce the amount of multiple pregnancy, and the goal is to keep the multiple pregnancy at less than 10%, not more than 10%. And what has been seen that as the years have gone by, we have found that if you see the square graph is coming from almost 25%, which was earlier present, it's now coming down more towards the 10%. Whilst the triangular ones which are there, the birth rate is going up, the multiple pregnancy rate is coming down as the years are going by. And I think as IVF specialists, we have all learned that we need to reduce the number of embryos we are transferring, because single embryo transfer, if you do, it's likely to have a significantly low live birth rate in a fresh cycle versus a double embryo transfer. So that everyone knows that if you put in 2 embryos, you get a higher pregnancy rate. But you are increasing the risk to getting a multiple pregnancy. But if you compare this, if you do a cumulative live birth rate, wherein you do 1 embryo transfer in the natural cycle and 1 frozen cycle in the next cycle, you will find that your pregnancy rates are almost the same or better when you as compared to doing 2 fresh cycles of single embryo transfer. So in short, we must keep the multiple pregnancy rates low, and by doing a single embryo transfer and lower the chances of multiple pregnancy. So there are various strategies again to reduce the multiple pregnancy. One is selective single embryo transfer. And we know that when we do double transfer, the monozygotic twins are higher when you compare even a single embryo transfer as compared to natural conception. With natural conception, the chances of a monozygotic twin is 0.4%, whilst with elective single embryo transfer, it is from 0.7 to 3.1%. Whilst when we do a blastocyst transfer versus a day 3 transfer, you'll find again that monozygotic twins are higher. Or if you do ICSI versus IVF, the monozygotic twins are higher. So in short, blastocyst transfer is a better option, and it's better to do single embryo transfer. Whatever we do in ART, in short, it's going to have some amount of increase in complication. Ectopic pregnancy and heterotopic pregnancy in ART is, again, prevalence of ectopic pregnancy is increased. The normal chance of ectopic is about 1 to 2% following natural conception, and it increases to 2.1 to 8.6% in ART. While it's a heterotopic pregnancy, wherein you have 1 pregnancy in the uterus, 1 pregnancy in the tube, in the general population, it is 1 in 30,000, and here it goes up to 8 per 1,000 cycles. So that's with ART. And the risk factors are cigarette smoking, previous pelvic inflammatory disease, endometriosis, previous ectopic, previous tubal surgery, and impaired tubal function. The ART-related factors for ectopic are basically there's a loss of normal biological interaction, which normally occurs between the endometrium, the embryo, and the fallopian tube, which is altered in this case where we are just transferring the embryo. There's an alteration in the hormonal microenvironment because of the hormones we have given to the patient. There could be a problem with embryo quality. There could be multiple embryos which are being transferred, or the technique of embryo transfer is not right, or it could be at what stage you are transferring the embryo. Besides this, there are other complications after assisted reproduction, and one of them is cancer risk, where it has been shown that cervical cancer, breast cancer, ovarian cancer, endometrial cancer, there is really no increased risk. But there have been a few studies which have talked about a small increased risk in women under 25 years of age for breast cancer, and a small increase in risk of borderline ovarian tumors. So this risk is something we have to remember, that is for the women. But when it comes to the children who are born of IVF and ICSI, it has been shown that childhood cancer is the second most common cause of death in developed countries today, where we still do not know the exact cause because various cancer registries in various countries are having conflicting data. Some talk about probably it's happening during the early stages of fetal development. It could be that the maternal progesterone is increasing the risk of lymphocytic leukemia and sympathetic nervous system tumors. And third is that the fertility treatment itself is causing the cancer risk, but still there is no significant association which has been found. The risk to the offsprings is that there are congenital anomalies which are definitely increased versus natural conception. The risk is almost 32% higher and 36% higher risk in singletons and 42% increased risk for major anomalies requiring surgical correction. Now, we do not know whether it is due to the underlying infertility in the parents or whether it's the procedure or whether it is the drug. But if you look at the overall increase, if you only count the absolute risk, it is about 7%, whilst the absolute risk in normal conception is about 3 to 4%. So here you have an extra risk, agreed, but when we talk in terms of percentages, it shows very high. There are imprinting disorders, which is a risk to offsprings born after ART. And the word epigenetics, which we talk about nowadays, is referring to the genomic information over and above the DNA sequence. So this epigenetic regulation is required for genomic function. And when there are epigenetic alterations to the imprinted genes, it can cause imprinting disorders. So there are certain disorders which are well established, like the Prader-Willi syndrome, Angelman syndrome, etc., which are really fatal syndromes and very, very, very disheartening when you look at these children. And these children born after ART have a 3.5 times higher risk of imprinting disorders versus naturally conceived children. So in conclusion, we must remember that OHSS is a serious complication of ART affecting women and children. Limiting the COS in high responders limits the hyperstimulation and the outcome of pregnancy that results from it. The goal of retrieving 11 to 15 oocytes per cycle may produce an optimal live birth, and it may limit the risk of OHSS without reducing live birth rate. The risk of hyperstimulation significantly decreases as the proportion of embryo banking cycles increases, and the use of GnRH antagonists during COS protective. Using a GnRH agonist trigger in women at risk of OHSS helps. Use of metformin, low-dose aspirin, cabergoline, appropriate embryo banking. All this will help instead of, by using these appropriately. It also, OHSS increases the risk of preterm labor and low birth weight by 1 week. So in short, when you have a single child, it's fine. 1 week doesn't make a difference. But when you have multiple pregnancy, there's already prematurity. Most of the babies are born at about 37 weeks. And if there's still a 1 week early preterm labor, it is a higher risk to the babies for sure. So this is what we have to remember, and therefore we must remember that moderate to severe OHSS is definitely preventable, and we need to make sure that we don't land our patients into that and prevent the moderate and severe hyperstimulation. Thank you so much for your kind attention.
Thank you, Duru, for that excellent lecture. So if there are any questions from the faculty, we could take. And I request all the participants to give their questions, because whoever have not given for all the talks, so we would have a Q&A session at the end of all the talks. So now we move on to the next talk.